Hello, I'm Dan Lamar. I'm with Coast Orthopedics and I'm a sports medicine physician. I've had the good fortune of being associated with a bunch of professional athletic teams to include currently with the Titans, and I've historically been with the Bucks, and some baseball teams to include the Orioles and the Pirates, and traveled around the world with the U.S. soccer team. So I've had some great experiences, but the conversation today is really more about the aging athlete, which hopefully has a little broader reach and appeal. So the concept is really what changes as we get a bit older, specific to our biology. So the biology of aging is mostly about, well, the bones, the muscles, the tendons, and the joints, right? That is what constitutes the musculoskeletal system. The bone density tends to decrease even as young as age 30. Muscle mass decreases beginning around age 30, and fast twitch fibers get lost sooner than the slow twitch fibers. Tendons start to lose some of their linear alignment and become more disorganized, especially in the high stress zones. And then joints, which is the issue that most of us face, the cartilage surfaces begin to thin, and the actual constitution of those joints begins to change a little bit molecularly, to include changes in the number of proteoglycans, which is really the stuff that allows for good cushioning in your joint and cause the viscosity of that fluid to begin to diminish. And therefore, the stresses on the joints increases. So, common overuse injuries. I thought we'd go through a few common overuse injuries specific to aging and things that I see a lot of in the office. Those include rotator cuff tears, golfer's or tennis elbow, and trochanteric bursitis, meniscus tears, and Achilles tendinitis. Those are probably the most common overuse issues. Specific to the rotator cuff, it does tend to be a repetitive overhead kind of use activity problem, and not every rotator cuff tear originates from a big traumatic event. So, in fact, most frequently these rotator cuff tears come about relatively insidiously, really without much of a suggested cause. And not everyone I see with shoulder pain that's around the rotator cuff actually has a rotator cuff tear. In fact, the majority of those have inflammation around your rotator cuff called bursitis, or even just inflammation within the tendon called tendinitis. So when we look at the anatomy, we talk about the muscles that surround the shoulder girdle, and there's 4 of them, and those come together to conform what's called a rotator cuff, which is basically just a coalescence of tendons and then their subsequent attachment onto the side of the shoulder. The importance of the rotator cuff is that it stabilizes the shoulder, and it's just a very frequently injured body part simply because of our design and the things that we do today, which perhaps we weren't evolutionarily built to do so quickly. So what are those things? So bursitis, again, is inflammation of this kind of cushion. We have bursa all over our body. We'll talk about another bursa here in a second. But bursa is just a very thin, fluid-filled layer that allows one structure to slide past another. Sometimes it's a tendon, sometimes it's a bone, sometimes it's a muscle. And all of those things can create opportunities to develop inflammation and friction, and therefore pain. And so frequently you'll get a little inflammation in this bursal sac. And then as they progress, sometimes it goes on to the tendon begins to become involved, and there's some partial tearing there. And then that can often progress on to small tears, which get bigger with time potentially. Our treatments for all of these issues tend to be, well, rest and activity modification, oral anti-inflammatories, which we refer to here as NSAIDs. Frequently we'll inject these. By the time you make it to my office, you've probably suffered through at least 1 and maybe 2 of the treatments, and then injection is useful and often the thing that breaks the cycle the most efficiently and kind of returns you back to your baseline. We will include some physical therapy along with that, and when things are bad enough or tears get big enough, we surgically repair them. Epicondylitis, which is golfer's elbow or tennis elbow, has most to do with an overuse repetitive wrist flexion and extension. Extension is what we use, it's been coined tennis elbow. These days it's much less common to be seen as a tennis player and more common to be using your iPhone or things of that nature that create this type of problem. It's really just a fine motor problem, overuse of all of the muscles that bring your fingers into extension, your wrist into extension, and therefore causes pain right at this one little insertion site on the outside aspect of your elbow. All of those muscles are attached to this one little site and therefore are high risk and very vulnerable. In fact, I think of this problem as fairly ubiquitous. Most of us suffer from it at some point. The good news is most frequently it goes away. The treatment strategy, and the same as the golfer's elbow, is just the same problem, inside aspect of the elbow, a little less frequent than the lateral side. So the beginning treatment strategy is ice it down, rest it, stretch it, take some oral anti-inflammatories. As you'll start to see, there's a theme here. Right? That's how we treat most musculoskeletal injuries until they get bad enough. And then we think about injection. We do various types of injections to include steroid injections to begin with, sometimes PRP and even stem cell injections. And they can be quite helpful. And when things are bad enough and just won't respond or fail to respond to several different of these injections, surgery can be needed, but that's the far minority. Trochanteric bursitis, similar to the bursa around the shoulder, there's a bursa that sits below a thick sleeve of tissue on the side of your hip called the IT band, and it rubs against this bony prominence called the greater trochanter. And so it's imaged here. So this is the edge of your hip, and it's very prominent. These muscles attach from the top called the hip abductor, and there's a series of muscles that attach there, and often they can become torn too, very similar to the rotator cuff. I like to think of this as kind of the rotator cuff of the hip with a very similar set of circumstances surrounding it. So you become inflamed, irritated, injections can help. When things start to tear, then we have to escalate the treatment and the evaluation, frequently including MRIs and things of that nature. So similarly treated as you would expect. We ignore it. Most of us ignore it for a long time. We at times stretch. We try and ice it down, cool it off, modify our activities, inject or use oral anti-inflammatories, and when those things stop working, that's when we escalate MRI and things of the such. And at times, not all that infrequently it does require a little bit of surgery. Meniscus tears, this is something I probably see, I would say 10 a day when I'm in my normal office day. They're maybe the most common knee problem that I see, especially as we get a bit older. Similarly, all those structural changes in the biology that we discussed at the beginning take center stage here, and they can start to then deteriorate and things start to break down, and the next thing you know, the tissue can tear. When people have a torn meniscus, they can tear in various different ways, whether it's a vertical tear, an oblique tear, radial tear. These are all just patterns of tears that happen, and they often do determine our treatment strategy. So for instance, if somebody has a vertical tear, a horizontal cleavage tear, sometimes they're not as symptomatic, and even though the MR reads as a meniscus tear, it's treated quite differently than, say, an oblique tear or a flap of tissue or a transection of the meniscus that often we'll see. So not all meniscus tears are created equal, and I get that question often that, well, my buddy had a meniscus tear and he got scoped and he's 100% now. Well, fortunately for me, that is the most common way it goes, but oftentimes when people have these more unusual shaped tears, they don't get better. But again, the treatment strategy, or the origin of them often is a load and twist. So deep squatted and you twist or change directions, and as we get older, these tissues just aren't as resilient to the same activities or motions we've probably done 1,000 times. Achilles tendinitis, again, a very common problem. I fortunately suffer from an actual tear of my Achilles. But the more common thing I see is folks that just start to develop a little inflammation in their tendon. The symptoms are usually really tough time in the first step, getting out of bed and walking. That tends to loosen up or warm up throughout the day, and then anytime we have periods of rest, resumption of activity is particularly painful. The treatment is really kind of rest, ice, boot, and then if you torn it or there's internal substance tearing that's been recalcitrant or resistant to treatment, then at times we do operate on that as well. Arthritis, this is number one, and this is the thing we see the most frequently, and that really has to do with the breakdown or wear and tear of that very important cartilage surface on the end of the bones. And it's every joint. Every joint in our body is covered in this very shiny, white, pearly coated hyaline cartilage, and as it breaks down, it starts to look more like a furry kind of surface coating. So when cartilage breaks down, the surface starts to kind of fibrillate, or small little surface elevations begin to happen, and then the fluid from the joint can get inside of that tissue, and then it escalates or precipitates even more breakdown. So we call it degenerative joint disease is another way to describe most arthritis, or the most common arthritis that we see. And as that surface breaks down, the wear persists, and then other structures start to break down, to include you get bony changes where you make all this extra bone around the margins, and we call those osteophytes. And so how do we treat these changes? Well, you try and reduce the activity or unload the most involved area of the joint. You try and, which often includes weight loss, maybe the number one thing. We use oral anti-inflammatories, we do injections, and when things are bad enough, that's when you or your friend or somebody you know, I'm sure, has had their joint replaced. We can replace parts of joints, the entire surfaces within the joint. One common misconception is that we actually remove the whole joint and install something, meaning en bloc, remove the area. That's not what happens at all. It's more of a resurfacing procedure, or a capping procedure, where we basically put an artificial surface on the either side of the respective joint, and then put almost an articulating polyethylene surface in between the two metal structures to allow it to glide smoothly. Emerging technology, you know, biologics have been around for quite some time now, and we're actually getting a little traction with some of the data. I've personally been a little slow on the uptake of some of these injectables, but I've embraced it recently because the literature has shown some significant improvement in arthritic and tendinopathic type issues. So whether it's PRP, which is platelet-rich plasma, where we actually draw some blood, spin it down in a centrifuge, and pull out the platelets and then inject those into the affected area. Or we use stem cells, which can be harvested from yourself, either from your fat or your bone, or frequently we'll use it from off the shelf, which can be harvested from umbilical cord or amniotic type tissue. Injury prevention, probably the number one thing. Flexibility, which I like the idea of dynamic stretching, which really has to do with movement and time. So not just static, kind of bend over, touch your toes, but warming up and then stretching as you go. If you surf the internet and look for a dynamic stretch regimen, you'd easily find one. I think that's the most valuable thing you can do as you begin to age. You know, I'm fond of the phrase, we're born flexible and we die stiff. You know, the longer you can stay flexible, you know, the better off you will be, there's no question. Cross-training, meaning, you know, most folks have one thing they really like to do. Pushing yourself to do some things athletically or physically challenging that aren't exactly the one thing you love may make you better at the thing that you do. And so, for instance, swimming or cycling for runners is often very effective, or even for golfers or tennis players to do something that's maybe slightly outside of their norm, to challenge their muscles and their tendons and their bones in ways that they don't normally see. Low impact activity, obviously that's better than the real high impact, especially as we start to age, even though we do like weight bearing type activities for good bone health. Avoiding ballistics, that means just explosive maneuvers. As we get older, these tissues just don't respond to those types of quick changes in length and direction, and you know, we all need to slow down at some point, unfortunately. But I do think that specific thing, if you can remove the explosive movements, often you can have a very long, healthy, athletic kind of career. Hydration, you can't overestimate that. And then the final thing is fatigue. You know, when you feel fatigued, you need to back it down, especially as we get older. Fatigue leads to reliance on the static structures such as your ligaments and your cartilage surfaces, and that's when injury happens, you know, that one last run down the slope. And that's it. Hope this was helpful. It's kind of a whirlwind tour of issues that involve the aging athlete. Again, I'm Dan Lamar. I work with Coast Orthopedics. We have a really stellar group of guys and girls that can help you with all your orthopedic needs.